Good afternoon, dear friends. I will speak on mucormycosis. It's a different topic from aesthetic surgery as well as our routine reconstructive surgery. But I know that most of us are facing this cutaneous mucormycosis problem in our cases. I will speak on this mucormycosis. I'll just discuss about this case. This patient is a 31-year-old female. It met with a road traffic accident last month. At the time of accident, she was treated outside and referred to us after 10 days of treatment. Initially, there must be some injury to the right upper arm. There was a fracture of the humerus, which was plated by an orthopedic surgeon. And after a few days of plating, he must have recognized that there is some injury to the soft tissue, so he did the debridement and plate was removed and external fixator was applied. And later on, maybe after a few days, he must have recognized that there is some fungus. So he started amphotericin and sent the patient to us. When we received this patient, there was a very extensive involvement of nearly circumferential involvement of the right upper limb, right upper arm, right arm as well as the dorsum of the hand. There is a total necrosis of the soft tissue. Most of the muscles of the arm has been necrosed. There are multiple patches of fungus was there on the both the hand as well as on the hand. So the patient came in the night and next day morning we took the patient to the OT just to explore whether we can save his limb. So when we explore in the operation theatre under anesthesia, we find that there is a very severe necrosis of all the tissue and it was very difficult to save his limb. So because we have not taken the consent, so we referred the amputation surgery and next day then we keep the patient for an amputation. But at that time we take the multiple fungal cultures and reports comes within 4 or 5 hours and it was a mucormycosis. So next day we took the patient and a high above elbow amputations were done along with the surrounding soft tissue, whatever the soft tissue was there which was necrosed. Again we have taken the cultures and next the cultures came and again the cultures were positive. So we did the debridement 2 times. And again, at the 2 times we took the cultures, and consecutively next 2 times the cultures were negative. Then for that we took the culture like this from different places at the intersection of the normal tissue and the necrotic tissue. And when we find that 2 times consecutively the cultures were negative, then we applied the VAC, and 2 times the VAC was applied, and finally on 11th of this month, we did the grafting and the graft was taken well and we discharged the patient on oral antifungal medicines. This is a well settled graft. Now the question is what is mucormycosis? It's a very life-threatening infection. We all know that it is because of the fungi of the order of murales. And the clinical symptoms are usually very elusive. Usually the clinical symptoms initially are non-specific. Usually there is some conventional technique which we have a routine culture and routine things are insensitive and very difficult to diagnose this until unless it is not in your mind. So there are different types of mucormycosis. I am talking about only the cutaneous mucormycosis. Most of the time, in our cases, particularly in road traffic accident, the root of infection is traumatic inoculation. These molds of fungus, they live in oils, decaying matter, substances such as fruit, cereals, bread. Other sources may be, because particularly in cases of hair transplant, when we do a multiple injection in patients who are taking on insulin, these are the main source of infection through which we get the mucormycosis. So there are a lot of risk factors in which our immunity is decreased in all major trauma, major burns, in diabetic patients, in malignant patients which have a malignancy, prolonged use of corticosteroids. These are all risk factors which help in doing the developing this mucormycosis. The mucormycosis spores, when they enter in our body, usually they are killed by phagocytes in normal healthy individuals. But when the patient is immunocompromised or sick, they usually escape by phagocytes and they invade the angiolymphatic system and they grow in perivascular and intravascular spaces. There is a hemorrhage and thrombosis and ischemia and necrosis, and then the process takes place like this. So usually the clinical presentation, I told you that it's a non-specific. Sometimes it's very difficult to detect in early phase. But usually there is a fever, there is erythema, there is a vesicles, pustule, cellulitis, edema, and then indurated plaques, and extreme cases there is some cotton-like growth. And in bone infection is usually rare, joint infections are very rare. So in cutaneous mucormycosis, it can be localized, it's limited to the skin and subcutaneous tissue. It can be deep, involving to the bone, tendon, and it can be disseminated to the other contiguous organs. And the reverse dissemination, from inside to the outside skin, is very rare. So the management is totally dependent on an early diagnosis. The management may be a surgical management and an antifungal therapy, and reversal of if there is any predisposing factor. So the important thing is a diagnosis of mucormycosis. Until unless somebody has a suspicion, there must be a high index of suspicion in the surgeon's mind that the patient can have a mucormycosis if your routine diagnostic tools, your routine treatment is not responding well. So the early diagnosis usually help in control of the infection. So because it is rapidly progressing basically, it's a very positive, there is a negative culture, there is unresponsive to the routine treatment. One must have in mind that patient can have a mucormycosis. So the important thing in diagnosis is that you must take a tissue basically, and one must take the tissue from interface from a normal and a necrotic or an unhealthy tissue and send it for a KOH. Because immediately you can have a report within 3 to 6 hours if there is a high load basically. So fungal culture and microscopy take a time basically. Maybe 3 to 6 days will take a time, but the first diagnosis can be achieved by a KOH. Usually when we take the sample, you should not crush the sample, you should not refrigerate the sample, and I told you that the KOH is used, and the presence of non-septate hyaline hyphae with irregular branching is usually seen by the microbiologist, and they give the report to us. Culture and sensitivity usually is reliable, but it takes time. And other methods like PCR, they are very reliable methods, but usually they are not available in most of the centers. The role of surgical is very important because we have to do a radical and serial debridement. A single debridement is not sufficient. It must be aggressive but conservative. So intraoperative frozen sections can be used. You must take and can send it for the lab for diagnosis of your area of surgical section. So primary fungal therapy, one has to start. If you even don't have a report in your hand, but you are suspecting a mucormycosis, you must start an antifungal therapy. Because as soon as we start an antifungal therapy, there is the chances of survival is increased basically. And this lipid formation of amphotericin B is a standard drug, and It is less nephrotoxic, giving safely for a longer period. Urinary profile is important because sometimes it causes hypokalemia. Dosage can be from 5 to 10 milligram per day as commonly used, and it must be stored in refrigerator. And this drug is very this photosensitive. So when we are transfusing, it must be covered with so that sunlight can't be there into the bottle or into the tubing. So this IV antifungal therapy is continued and the patient is stable, signs and symptoms are diminished, and your wound is negative for consecutive 2 times. This amphotericin B is also available in a topical form, so that you can also use it as a ointment. Once we stop this IV amphotericin, then you can step down to a isavuconazole, and it is available in both the form, parental as well as in a oral form. So the overlap must be for a period of maybe 3-4 days. After patient improved clinically and cultures are negative, oral formulation can be continued for another 2 to 3 weeks. So other therapy, people are saying that hyperbaric oxygen can be used, but we have never used it. But people are showing the improved result. The surgical challenge is, in spite of all its effort, there is a surgical challenge. There is limitation of debridement, especially in the large areas communicating with the cavity like abdomen, perineum, chest, and oral cavity. There is a challenge in medical management and surgical reconstruction, and challenge in targeting primary comorbidity. So this is another patient which have a hair transplant, and after 10 days of hair transplant, he developed some swelling, some necrosis, some edema into the tissue, and not treated by routine treatment, and he developed a mucormycosis, was diagnosed. He did the debridement, and later on it was covered with a skin graft. Similarly, it's a road traffic accident. Patient had a trauma on the chest and abdomen, and initially it was not diagnosed. Later on, when the patient was referred to us, we suspected mucormycosis, and we did the debridement, and then the skin grafting has been done. Similarly, this patient has a diabetes mellitus, chronic liver failure, so developed a mucormycosis, and later on amputation has been done. This is another patient with a road traffic accident, having a cervical injury with some injury to the scalp, and later on he developed a mucormycosis, and again a debridement and a skin graft has been done. So this is really a very challenging to the plastic surgeons, and sometimes even with all these efforts, we sometimes are not able to save these patients, and patient basically die in spite of all our management. Thank you.
Questions, please. Thank you very much, sir, for your information. Just one question. How do these infections clinically look different from mycobacterial, atypical mycobacterial infections?
Basically, in a microscope?
No, clinically.
Clinically, basically, it's very difficult. They are non-specific. It's very difficult to diagnose whether it is a bacterial, whether it is a tubercular, whether it is basically. It's only you have a high index of suspicion that by the routine treatment, if something is not, your patient is not improving, there is a necrosis. Basically, particularly in these cases, there is a necrosis. There is a blackening of the tissues in the wound. Then you suspect that it could be a mucormycosis. And diagnosis is immediate. Within 3 to 4 hours, you can have a diagnosis if you are a good microbiologist there. Just send that tissue for a KOH, and they will tell you that it is a mucormycosis. It's basically a fungal, non-septate hypofungus. They will give this diagnosis. So you start with
If I may add a few points here. One, mucormycosis generally, because it's angio-invades, so the wound will look dry, woody, hard. As if it's a bacterial infection, it's generally more wet. So that is the first suspicion. Secondly, what we have published a paper on this as well. So when you suspect mucormycosis, you start antifungals, as sir has already mentioned. Secondly, you don't take the patient for debridement directly. What happens is, you start antifungals. After 48 to 72 hours, once the antifungal levels are there in the bloodstream, then you do the debridement. Because otherwise, invariably, the margins will spread. Thirdly, you have to do a wide local excision. It's like a cancer surgery. So you take 3 to 5 centimeter margins from wherever you feel the induration. And that's how you excise. And another thing is, with amphotericin, probably it's the only antimicrobial which has a topical action. So you use liposomal amphotericin for IV and non-liposomal, which is much cheaper for topical dressing. We had a case post-liver transplant with mucormycosis in the wound. Patient had thrombocytopenia, so we could not operate. So with just local dressings and topical amphotericin, we were able to manage. So topical amphotericin also makes a lot of difference in such cases. Earlier we used to have a gel also, which was available. Now we don't get it. But topical amphotericin soaked gauzes work wonders. After you have sure that it's negative. So you take KOH mounts. What normally we do is we take KOH mounts from the margins, sir has also mentioned. And once they're negative, then you put a back. Otherwise, once you close it, you'll not know what's happening inside.
Only put a back only once you are sure. 2 consecutive negative reports must be there before doing any surgery. Another thing that I don't agree that you have to wait for debridement for 2 days and the first method. Because if you wait for 2 days, ultimately the wound will again it will.
So what we have seen is that initially we also used to do the debridement immediately. What we have seen is that the extension of the margins is much faster if you do it without starting amphotericin. Once because amphotericin, whenever you start at a low dose. Normally in an adult patient it will be 50 milligrams TDS diluted in 100 ml of D5. So once, and gradually it is increased to 200 milligrams TDS in D5. So once the levels are achieved in the blood, the spread of the fungus at the margins is lesser. Of course, you can do a local cleaning of the wound, but a proper debridement in our center, we prefer to wait for 48 to 72 hours before we take the patient for a debridement. But amphotericin, of course, is started on the first suspicion, even without waiting for a report.
Thank you.
Now this is the final topic pre-lunch. After this topic we are going to have oration, Professor C. Balakrishnan oration. For the last topic of the session I request Dr. Anil Kumar Morarka. He is going to share his experiences regarding radiofacial surgery with us.
Dr. General, Dr. Gaba, for inviting us and giving us this opportunity to present our work. And this is what I'm talking about. This is the branch which needs a lot of attention from all of us. In fact, especially youngsters, because this is a good branch, and if we do it properly, we can give up fantastic results. I'll be showing my results and my spectrum in the lecture. Otherwise, this branch is like drifting from the plastic surgery and going more towards the maxillofacial surgery. So this is the thing which we need to be worried about. And this is our department headed by our ever energetic Mohit. We have a maxillofacial surgeon also working with us along with other plastic surgeons, and this gives us like advantage of getting the good knowledge of maxillofacial part also. And his wife's an orthodontist, so that completes our craniofacial team. And since the time we have started working as a team, our results are much better, and we can do a lot of complicated cases and produce good results.
And this is the envision, like this is our motto that everything should be provided under one roof, and we are trying to achieve that. And I'll start with a very common problem of cleft lip. Almost everybody of us is doing this. We are getting very good results also, but I like to emphasize that this is not a single stage surgery. This requires multiple surgeries according to the age and according to the need. And if we follow the protocol properly, and that includes speech therapy, ABG, and orthodontic treatment, and if required, orthognathic, and if required, rhinoplasty, we can get results like this also, where you won't find any stigma of cleft lip and palate. And this is a young boy. I'm not showing this speech sample, but believe me, his speech also is fantastic. So he underwent cleft lip, cleft palate, ABG, orthodontic treatment, then orthognathic surgery, and that was Bimax, and the last rhinoplasty. And this is what we could achieve. This is a bit more complicated facial cleft, but if we apply plastic surgery principles and if we do it properly, we can get fairly good results. And if you see, the eye looks quite okay. Maybe a little bit more work near the medial canthus area on the left side. The hardcore craniosynostosis or the craniofacial surgery, where it's a craniosynostosis, where we have premature fusion of sutures, and this is what we get according to the sutures involved. Metopic suture fuses very early, around 6 to 9 months of age. Rest of the sutures fuse in the adulthood, and this is what is the deformity we get when the sutures are involved. And I'll show you the different examples. This is one of worldwide, sagittal synostosis is the most common, but in India, we get more of unicoronal synostosis, and this is one of the examples. You can see the right side of forehead is depressed, and you can see on the CT that right side of coronal suture is fused. And this is how he looks after frontoorbital advancement and remodeling, and this is what is the late result. If you see here in the pre-op pictures, the nose also is slightly deviated. But if you see here in the late post-op, the nose also is centralized. So if we correct properly, and if you do the surgery properly, it automatically gets corrected. So the aim of doing craniosynostosis surgery is to give brain more space and to prevent further deformities. And this is what is I want to show in this slide. Then this one is the second most common in our country, and that is the metopic synostosis. And you can see the CT scan where the metopic suture is fused. This is the boy from Kashmir, and this is what is the post-op picture looks like. Then we come to bicoronal synostosis. This baby came from Bangladesh, Chittagong, and where both the coronal sutures were fused. You can see a brachycephalic skull, tall and flat forehead, and this is how she looks after correction, fairly rounded forehead and correction of brachycephaly. And this is the late post-op where she's like sitting along with her twin sister. And there's hardly any difference. It looks absolutely, the long-term results are still maintained and it looks good. This is the sagittal synostosis, one of the few rare ones which we have done. And this is the one who came from Uzbekistan. And we did complete total cranial vault remodeling. And this is what the post-op picture looks like. And in the side view, you can see a correction in a better way. And then if you see, the forehead also looks much better now, and the occipital bullet which was there in the pre-op has been corrected in the post-op picture. And this is a multiple suture synostosis where metopic and coronal sutures are fused. This is a non-syndromic one. And this is how she looks after correction using frontorbital advancement and cranial remodeling. And that's the late post-op picture. The results are maintained very nicely. And this one is the syndromic one where multiple sutures were fused. And this boy, nowadays we have started using posterior wall distraction as a first stage in the first treatment. But this was done before that, and in this case we had done frontorbital advancement in the first stage, and in the second stage we did posterior wall distraction. And the perioperative pictures are there, and you can see the posterior wall distractor being put. And this is how the boy looks after completion of the posterior wall distraction and frontorbital advancement. The advantage of posterior wall distraction is that it's a fairly simple procedure and doesn't involve the you don't have to do elevate the posterior occipital flap. You just have to do craniotomy and put the distractor. And because there are not too many important structures on the back side, you can distract up to 3 centimeters also. So ultimately, the intracranial volume increase with this is much more in comparison to frontorbital advancement, which was the mainstay of the treatment till now. And this is again a much more complicated one with the clover leaf skull, and this is again treated using frontorbital advancement. You can see the plates there, and then posterior wall distraction was done, and this is how the post-op picture looks like. The head, which was tall and narrow, looks fairly normal. Then we come to hypertelorism. That means the increased distance between the two orbits. And this is one of the most complicated surgeries in craniofacial surgery. And it can be treated by facial bipartition or box osteotomy. I'll show you a few examples of both the procedures. And this is the toughest one which we have done till now. This is the 4 years boy. I was following him from the age of 6 months, and he was seen by everybody in the Delhi and was referred to me. And 6 months was too young an age, so we didn't do it. And around 4 months, 4 years of age, we dared to do this. It's one of like the very difficult ones. And I mean, that is okay, but along with that, there's so much of social problems. The parents had hardly any social life because of the kid with so much of deformity. I mean, they couldn't go out, the kid couldn't go to the school, couldn't play with the children of his age, because everybody used to stare, and they used to get scared of also because of this much of deformity. Anyway, we planned it very nicely using virtual surgical planning, mock surgeries, nylon model, and everything was planned absolutely nicely, whatever we could do. He had basal encephalocele also and cleft palate also, and intraorbital distance in this case was about 7 centimeters. And you can see the basal encephalocele, which further complicated the surgery. And this is how the planning was done, and we used facial bipartition in this case. And we reduced the intraorbital distance from 7 centimeters to around 18 millimeter. And this is the planning which is there. And these are the perioperative pictures. You can see the intraorbital distance has come down along with the, and we reduced the encephalocele also. And whatever extra skin was there on the dorsum of nose, we excised that. And there was we put a cantilever bone graft for the dorsum of nose. And this is how the baby looked after 18 hours of surgery, just before shifting out to the ICU. And this is how the long-term result looks like. The child is doing absolutely okay. I mean, post-op period was fairly stormy. He had a lot of problems, but ultimately he came out. And this is how he looks. He's much better now. He's a happier child. He goes out to play, and his parents have a lot of relief because they have some social life also now. And this is how the post-op CT scan looks like. Again, a child with grade 3 hypertolerism treated with box osteotomy this time, and you can see the area of the bone which was excised, and after reduction of, after approximation of the orbits, and you can see the video, small video, which is showing that this is how both the orbits were like brought in the midline and the after fixation. And this is the immediate post-op and the 1 week post-op picture looks like. And this is the post-op CT scan. And this is the boy, this is a picture which was sent to me by from Iraq, his native country. And he was standing with his brother there. I mean, hardly, apart from the nose, he looks absolutely okay, which can be corrected. The nose can be corrected or improved. This is the girl around 6 and grade 3 hypertolerism, and that's the late post-op picture, and she's 20 now. When we operated, she was 6, and now she's around 20, and she finished her studies, and this is how she looks like now. This is a girl with the hemifacial microsomia, and we treated her using bimaxillary distraction, and you can see after completion of distraction, the symmetry is much better. She was a nurse with us with the hemifacial microsomia. We treated her using bimaxillary surgery and genioplasty, and hemifacial surgery. Anyway, this is a hemifacial microsomia. You can see the side view. The chin position looks much better. This is the boy who came from Ukraine with Peri-Robin syndrome. We treated him using mandibular distraction. He was CPAP and oxygen dependent, and when he went, he was absolutely okay without any support. Orthognathic surgery is the one which is very rewarding if we plan and execute properly. Results are absolutely instantaneous. And this is the boy which was treated using Leaford 1 osteotomy. These are the preoperative pictures. And this is the plan, and that's the post-op occlusion. And if we see clinically, this is how the pre and post-op picture look like. And that's the side view, and you can appreciate the difference. Again, a lady from African country, and you see the class 3 malocclusion, and with maxillary retognathia, again treated using Leaford 1 osteotomy and BSSO and genioplasty. And this is what is the occlusion we could achieve, and that's the X-ray showing the planning of the movement. And this is how she looks in the front view, and this is the lateral view. You can see the difference. And this is a girl who who is a doctor now. She had a lot of problems, and you can see the nose, and you can see other things. We did multiple surgeries, and that included orthognathic surgery and plus rhinoplasty. And if I show you the final picture, you'll be amazed to see the difference. And this is how she looks now. This is the girl 17 with Cruzon syndrome, and she required movement at the Leaford 3 level, but Leaford 1 level also had some retrusion. And I meant to say there was a differential movement which was needed, and we combined Leaford 3 plus 1. And this is how she looks in the frontal view, and and that's the post-op occlusion. And this is what is the lateral view looks like. This is 8 months post-op, and that's 1 year post-op. We get a lot of patients with the TM joint ankylosis. Nowadays we are not getting that many, but we do get deformity because of the TM joint. And what we have been doing now is alloplastic total TM joint replacement along with the orthognathic surgery. And this is the girl who is a dentist, came with the TM joint ankylosis, was operated multiple times. We released it, and after 2 years, when the mouth opening was okay, she wanted her deformity to be corrected, And we replaced the TM joint using alloplastic implant, and along with that we corrected her deformity with the orthognathic surgery. And these are the post-op X-rays, and this is how she looks in the post-op picture. Obviously, a little bit of AI enhanced picture, but she's much better now. And again, a girl from North East, same kind of deformity and same kind of surgery, and this is what is the post-op picture looks like. Facial trauma, we get a lot of facial trauma, and this is a girl who had a gunshot injury with the comminuted fracture of the mandible, treated using load-bearing implants, and this is how she looks after open reduction and internal fixation. And the last picture shows when her dental rehabilitation also was done, and that's the final picture. This is again a boy with the front fracture zygoma and the orbital floor, and with the anophthalmos and hypoglobus, we corrected everything, and this is how he looks. You see the eye projection looks absolutely okay. There was no diplopia, and eye movements were absolutely okay. And this is the panfacial fracture. You can see the CT scan, nasoethmoid fracture, zygoma fracture, maxilla fracture, mandible fracture, even the condylar fracture. We treated everything, and this is how the post-op picture and the last picture after dental rehabilitation. And that's the advantage of having a maxillofacial surgeon working along with you, and the dental rehabilitation part can be taken very nicely. Then we do get a lot of patients with the secondary deformities, and this is a boy who came with the orbitozygomatic fracture quite late, and he had eye movement restrictions, so we treated the malunited fracture with the with osteotomy and anatomical reduction, and their orbital floor was reconstructed. And this is
so
how
can
the
we please speed up?
Yeah, sure. Post-op picture looks like. Then nowadays we are doing a lot of virtual surgical planning, and this is the man, a BSF guy with a deformity like that, and this is the post-op picture looks like, and this is the girl and TM joint ankylosis problem. We treated her with replacement and orthognathic surgery, and this is how she was planned, virtual surgical planning and patient-specific implants, and this is the post-op picture with the complete correction of the occlusal cant and the deformity. Again, a young boy with the hemifacial microsomia, and this is how the pre-op picture looks like, and this is the virtual surgical planning along with the patient-specific implants, and these are the post-op CT scan, and these are the post-op clinical pictures along with orthognathic surgery, patient-specific implant, and TM joint replacement. And this is our craniofacial team. We have two pediatric neurosurgeons and one orthodontist and one maxillofacial surgeon. And thank you.
Thank you, sir. Thank you very much. We welcome our chief guest and patron, Director Karnal Medical College, Dr. M.K. Garg sir, along with Dr. Uma Garg, his wife, who is HOD ENT at Kanpur Medical College. We welcome you, sir and ma'am. Now it's a high time for Dr. Balakrishnan oration, and I invite Dr. Atul Prashar, who is Professor and Head of Plastic Surgery Department at P.
Thank you, Chairperson, for a nice introduction. So, very good afternoon, Chairpersons, teachers, senior members in the audience, and residents also. And it's my proud privilege to be standing before you and present this prestigious oration of this association. So before starting, let's talk a bit about who was Dr. CBK, as he was commonly known as. Dr. Chakri Balakrishnan is considered father of plastic surgery in modern India. So he was a colossus. He wanted to start the specialty of plastic surgery in India after independence, and his efforts bore fruit, and we could start a plastic surgery unit in Medical College Nagpur in 1957, and he joined PGI in 1966, and we started with MCH program in 1967. So he was, as a single person, he was responsible for starting MCH plastic surgery program in close to 12 centers in India. He was also awarded BC Roy Award in 1978. Most of the plastic surgeons know him for triple wedge technique and Nagpur classification, which is a classification of cleft lip and palate. But he also had many new things to his credit, like toe joint transfer for TM joint ankylosis, vertical oblique mattress suture for anterior urethral reconstruction, hypospadias, cheek skin buccimeter mucosa flap for reconstruction of major loss of upper and lower lids, and pharyngoplasty using facial data. So during his tenure, 44 MCH students he trained, and the teacher is known by the students he trains. Just go through the names of the students. Dr. C.S. Sundararajan, Dr. Sam C. Bose, Dr. R. Venkateswamy, Dr. L.K. Sharma, Dr. S.N. Sharma, Professor P.S. Chari, Dr. R.K. Nair, Dr. Ashok Govila, Dr. P.A. Vinod Kumar, and our very own Dr. Ashok Gupta, who is sitting with us in the audience. In the picture you can see is the Nzapscon 1985. Here is Professor C.B.K., Dr. Ramesh Sharma, Professor Chari, Dr. Ashok Gupta, Dr. Ahuja, Dr. Lakshmi, Dr. Karun Agrawal, all of you can see. So he superannuated in 1980, but he has left a great legacy, and I think this legacy will continue to guide us and many generations of future plastic surgeons. So the topic for my today's presentation is past foundations and future perspectives in relation to plastic surgery. So plastic surgery has been done since ancient times. You can find reference to plastic surgery of the nose in papyrus of ancient Egypt in 1600, which can be dated 1600 BC. But it was Sushruta who gave basic principles of plastic surgery. He was a great sage in an area around Kashi, and he is also the author of Sushruta Samhita, and he is considered the father of plastic surgery, ancient plastic surgery. And his techniques were followed in Indian subcontinent, but what about the rest of the world? So from 100 BC to 15th century AD, Romans used to do some basic plastic surgery, including management of damaged ears. And the medical writer Celsus, he authored the encyclopedia De Medicina, in which plastic surgery of face was described, and also skin from other part of body was used. And this had been the guide for plastic surgery close to 1700 years. Again, it was Sushruta Samhita which was translated to Arabic in 15th century AD, and plastic surgery spread throughout Europe. Italian surgeons Gustavo Branca, Antonio Branca described rhinoplasty techniques, and they were further augmented by Tagliacozzi. All of us are aware of this nasal reconstruction using the arm instead of forehead cheek, as Sushruta had described initially. And first time the word plastic surgery was used by von Graefe, Karl Ferdinand von Graefe, who in his book Rhinoplastic, in which he described rhinoplasty and used plastic for the first time. And again coming back to Sushruta Samhita, skin graft was rediscovered from Sushruta Samhita, and it was Ferik Jean Gael and Jacques Reverdin who described the skin graft in a manner which we do it now also. Again, breast augmentation was done in 1895 using tissue from the back of the breast. And it was First World War when modern plastic surgery came into vogue. What happened was, during trench wars, most of the injuries were in and around the facial area. They were fit individuals, but with a lot of deformity. So, Sir Harold Gillis, who was initially an ENT surgeon, he is considered the father of modern plastic surgery, and he described tube pedicle flaps for reconstruction of these defects. And then plastic surgery spread in US. The first training program started in Johns Hopkins in Baltimore in 1924. Kazanjian, Melinek, and Offish, all these great surgeons came together and started American Society of Plastic Surgery in 1950. Joseph Murray, who was a plastic surgeon, did a renal transplant, the first renal transplant in 1954, and he also got Nobel Prize for that. That was later. And thereafter, plastic surgery really took off. Every year there were new innovations and discoveries. Cronin designed silicone breast implant in 1961, and it was implanted in 1962. Ackland described microsutures as microsurgical instruments in 1971. In 1970, basic technique of liposuction was described by Arpad and Fisher, which were later elaborated by Illus. carbon dioxide laser technology came in 1980, and then we have most of us will be aware of, perforator flap described by Koshima, endoscopic plastic surgery techniques in 1990s, and with the dawn of 21st century, super microsurgery took off, and Botox was approved by FDA, dermal fillers, laser treatments, chemical peels, fat grafting, stem cells, PRP, minimal invasive procedures. Now the focus is more on holistic procedures, and we combine surgical and non-surgical treatments. So that is the way plastic surgery has evolved over the years. So we have made tremendous strides. We operate head to toe. We do replants. We do transplants also. We do reconstructive. We do cosmetic surgery. We do fat grafting, stem cell, PRP. We do minimally invasive procedure and also non-surgical treatments. This is the look at the number of plastic surgeons. And in case you look at India, with a population of 1.5 billion, we have around 3,000 trained plastic surgeons. So there is one plastic surgeon for 5 lakh individuals in this country. This appears to be a significant position of power for the plastic surgeons. But is it? As Frank Hubbard said, to come under siege was the inevitable fate of power. And that is what we are seeing. You talk to any young plastic surgeon who passes out, he says that aesthetic surgery is plagued by wannabes. Surgeons from sister specialties want to do what was initially plastic surgery domain. We can take it that with a pinch of salt, but even non-surgeons want to do that. And the point, let's discuss what are the reasons why everybody wants a piece of the pie. And we should know that it is not something very new. Plastic surgery has been under siege for a very long time, since the beginning. We have been developers of the technique, and then other specialties take over, and we simply used it. In 1970s, plastic surgeon when it developed, pec major was developed, DP flap was commonplace. Head and neck resection and reconstruction was done by plastic surgeons. The concept was any other surgeon will not excise it completely because he or she doesn't know reconstruction. And plastic surgeon knows the reconstruction and he or she will excise it and reconstruct it. But now what is the scenario? Head and neck surgeons do the both. They will do resect. In very few centers plastic surgeons are called. That is today's scenario. And then let's look at cleft lip and palate surgery. We described all the techniques, triangular technique, rotation advancement, and then we started sending for ABG to maxillofacial surgeons. And now you look at our Indian Society of Cleft Lip, Palate and Craniofacial Anomalies. We are outnumbered significantly. So this is a problem. Hypospadias, most of the senior surgeons would have learned during the residency, but now hardly any patient will come. Either urological surgeon or pediatric surgeon will do. Initially, hypospadia used to come to us because we were considered masters of operating under magnification. But that is not the case any longer. We hardly see, especially in PGI, hypospadias coming directly to us. We get only cripples. So, you look at brachial plexus and hand surgery. There is again specialty creep. So, probable reasons. One reason is plastic surgery is the region is not specific. We say we operate from head to toe. Ideally, we should have everything, but in fact, we have nothing which belongs to us, and we are not the gatekeepers. Most of us will rely on other specialties for referral. And another thing is, I talked about the number of plastic surgeons in India and the population. It is the high volume conditions where you will see a lot of creep, like hair grafting, fat grafting. So it is lucrative, and there is room for others. Once plastic surgeon for 5 lakh people is not enough. And then comes the logistical issues, availability. Even in tier 1 or tier 2 cities where plastic surgeon is commonly available, breast surgeon or head and neck surgeon will try to call the patient initially, in his initial cases, but usually plastic surgeon will be busy. Except in areas where the teams have formed, where the teams are not there, the surgeon will be late and there will be planning issues and logistical issues. So instead of waiting for the plastic surgeon, he or she will start doing the case, and lo and behold, over next 2 to 3 years, he will simply not call the plastic surgeon. So this is the nature of our specialty. So should we be despondent? Not exactly. You see, what one deserves and what one experiences is seldom congruent. Jim Butcher. So this is across the board, in all specialties, in all 4 hours of life. It is not only with us. So we should try to find solutions. Solution number 1, be the best. You should be very meticulous and everybody should know around you that you do the procedure in the best possible manner. Second is a bit challenging, it could be inconvenience, but be available. When anybody calls you, try to be there and be affable. Gone are the days of arrogant surgeons who used to think what you have done, how you have excised, I'll come and reconstruct it. No, this will not work. We have to be affable. So be the best version of you. And then collaborate. Dr. Murarka has shown an excellent example how we can collaborate and grow with maxillofacial surgeons, with other surgeons. Because in collaboration you have to give something and then take something. You cannot say I'll do it completely. And try to become the part of the team. Team together, everyone grows and achieves more. What happens is, whenever you are operating with other specialties, you would come across that some problems you face regularly. But while operating with them, other specialty might have a very simple solution to address those. So, as a team, we grow. We also grow, they also grow. So, team doesn't mean that you be there as a technician in operating room. The ENT surgeon has excised or head surgeon excised and you arrive at 2:30 to do the reconstruction. No. You have to be part of multidisciplinary conferences and boards, tumor boards. And the involvement means participation, not just showing up. And all the plasticians should also attend the common specialties like head and neck oncology conferences and breast conferences. I think most of us are now started doing it. So we should know, in word of Michael Jordan, talent wins games, but teamwork and intelligence wins championships. Next is social media challenges, which we are facing currently. All of us have social media accounts, and the dilemma of a plastic surgeon is, should I be using a professional social media account for getting more patients? Some people will outrightly reject it. Some will say it is non-professional. And again, there are patient privacy issues, which is an accepted problem. So let's look at the patient perspective so that we have some light at the end of the day. So this is 2020's figure. We had 1.8 billion users of Facebook, and this figure now is 2 billion. Instagram, 600 million monthly users, which was launched in 2010. In 2020, we had 600 million. Now we have 1 billion users of Instagram. So the point here is the penetrability is there. All these social media platforms can help you. Let's look at the social media usage as professional case scenario, not as personal, professional. So these are Western figures. Aesthetic surgeon, craniofacial surgeon, hand microsurgery and others. You will see more than 80% of the surgeons who are doing practicing primarily aesthetic surgery have a personal web page, and more than 60% have the professional Instagram account. Compare this to a craniofacial surgeon. 40%, hand surgeon, again 40% of personal website, and Instagram still lesser. So coming forward, let's look at the following of plastic surgeons. Instagram was launched in 2010. So average number of followers of plastic surgeons, highest number is around 12,000 on an average. So the people who passed out in 2010 had maximum number of followers. What about the people who passed out earlier? They have less, they have a bit more. But as you go ahead, you see in 2015 those who passed out, or now 19 those who passed out, they are more exposed to social media. They should be having more followers, but that is not the case. What's the reason for that? The answer lies in this regression analysis. So we look at this chart. These are the Instagram posts per month, and this is the website traffic which the plastic surgeon has. So as the Instagram posts keep on increasing, there is not a significant increase in daily website traffic. So Instagram posts simply do not matter. They matter to a certain extent initially, but on long term and higher number of posts do not make a difference. So what makes a difference? The difference is made by practice website. Website is available across the board in all platforms. So for the patient point of view, more than 55% patients are influenced by the website while choosing a surgeon, and whenever they have taken an appointment, more than 65% will look at the doctor's website before doing the meeting with him or her. Look at the Facebook, YouTube, Instagram. So they are not effective media. What do the patients want? Because of YouTube and Google, most of the 25% patient look for the information about the procedures. But more than 50% look for before and after photographs. So for the residents, during residency only, you should start keeping records so that you can show before and after photographs. And these are the most important things, because in website you also get patient testimonials and practice information. But the most common thing is before and after photographs, and then is information about the procedures. So website is more effective for many other reasons. There is relative permanence of information and depth of information is provided. And there is ready immediate access to photographs, videos, patient testimonials and blogs on a single platform, as opposed to fleeting nature of social media. You might get interested in a post, but 10 days down the line, you may not be able to find that post on social media. Archive post search is laborious. So website, what is the solution? Website is a centerpiece of practice online content. Social media can be adjunct to engage the users to explore the practice website. This is the take home from this. Then we have talked about the social media challenges. Let's talk a bit about future. First is technology disruptors. The common buzzword is AI. What exactly AI does? AI are the algorithms which mimic the processes of human brain. Like these are dendrites which will take, there will be receptors, there will be processing, there is the input layer, processing and output layer. Similarly, various inputs are given weights. These weighted sum is found out by the computer. There is the processing layer and output is generated. So, but that is the computer we know for long. So how does traditional programming differ from machine learning or AI? In traditional programming, what happens is, we want to differentiate between, the program wants to differentiate between giraffe and elephant. So giraffe has 4 legs, long neck, small ear and no trunk. Elephant has 4 legs, short neck, large ears and long trunk. This is fed by the programmer, like the coder. All the computer graduates, they will code it. And the computer will give answer. Usually it will be correct, but then a person has to give the answer. How does machine learning or AI differ? In this, we'll take lakhs and millions of photographs of giraffe and elephant and tell the answer to the computer that this is giraffe, this is elephant. The program will be generated by the computer. That is machine learning. So this is the basic difference. And then look at, in addition to machine learning, what is deep learning? In machine learning, we tell the computer, look at the eyes, look at the nose, look at the lips. The computer will classify each of them and develop a facial ID system. But in deep learning, nothing is told to the computer program, and input is just the photograph. Computer will find its own facial feature extraction and classification and develop a facial ID. So we are moving from assisted intelligence to now to augmented intelligence. All of us have seen those Google glasses and AR headsets. And we are proceeding towards autonomous intelligence. So this is the man-machine continuum. And we are likely to reach singularity. Singularity means when we don't even have to tell the computer to look at this photograph. And computer doesn't need the man. And some people say singularity will be achieved by 2030. We are not sure what will happen, but at least we are sure that we are into this area of augmented intelligence already. Just to know, computer vision, everybody knows, past 5 to 7 years in India and 10 years internationally. In case you jump a red light, immediately you get an SMS that you have been challaned. So this technology is already available. All of us talk to Siri and Alexa and find the answer. This is known as NLP, Natural Language Processing. In addition, there is robotic process automation. The repetitive end-to-end processes like billing, claims, administration. So IPD staff the people in corporate world will know is decreasing and AI is taking over. There's another benefit, there are no human errors and increased productivity. So organizations will invest in the AI embedded technologies, and they are. And there are visual based specialties like radiology, pathology, dermatology, ophthalmology, which are primarily visual based. So they are also using AI sooner than us. Cardiology is doing that. So we can get pre-operative patient specific data. AI algorithms can be run on that. This is the pulse rate, this is the respiratory rate, this is the saturation, this is the blood pressure, this is the age. So the surgeons can assess the surgical risk and it can help them in patient selection. And we can use AI enhanced robotics. Da Vinci 5 is already here with us, which uses AI enhanced robotics, so that the tissues are handled the way they should be, depending on their softness and their vascularity. We very soon will be having semi-autonomous surgical robots. So where does AI come in plastic surgery? We can use it to assess burn depth. Tomorrow we'll be presenting this paper also. Burn depth and healing times. We get a patient, 49 years of age, female, 10% burns, HB of 13.2, creatinine of this. So this is what we get. Skin graft, depending on the photograph, skin graft will be needed, chances are 66.9%. The adverse effect chances are 88.9%. Prolonged hospitality more than 14 days is likely 66%. This is the possibility. So we can prognosticate what is going to happen, and so can the patients. That will improve the communication between doctor and the patient. We can also use AI to detect early vascular compromise. We can we can preoperatively assess and plan the flap so that efficient use of the available tissue is done, because we can feed the data of perforator, the size of the limb, the size of the defect, and pre-operative flap planning can be done, like it has been done in automobile sector for using a piece of leather for making a seat. So most efficient utilization of the skin can be done. And there is something known as CNN. CNN is convolutional neural networks. It is a form of deep learning in which computer can be told to identify that this is normal, this is meteopic front, this is sagittal, this is unicornal synostosis, all these photographs. So already there are published papers in which with a single photograph from the camera, this can be identified, craniofacial anomalies can be identified 19.6% of time. This may not matter to us, but for a peripheral center doctor who is just MBBS, he can know the diagnosis, and with the help of computer, he can know what is the indication, what is the need of surgery, if any, what are the specialists he or she needs to send them to. This can be easily done. What is for plastic surgery, we can have a virtual assistant. So most of the time while discussing about the case to the patient is more than 70% we spend time in explaining the procedure to the patient. This can be easily done by a virtual assistant. All of you are using Swiggy and other platforms, and you know most of the communication is done by the bots. So this is going to come to plastic surgery also, and this can be helpful. This will increase the efficiency and reduce the cost. Radiology, this AI technology is looking at the epiphysis and telling the age. Similarly, fracture can be identified, and to carry it forward, the type of surgery which has best possible results can also be enumerated with the X-ray itself. This will enhance the decision making and improve the diagnostic accuracy and planning. We have learned about augmented reality. I was talking about Google Glasses. There is a heads-up display of everything, the turn you should take, what is the temperature like, and we are also aware of XR, augmented reality headsets. So how is this useful for us? Could be useful for us. So most of the microsurgeons suffer from neck pain and back pain. Reason is they have to look down. So what if in case you can project a 3D image? Exoscopes are available, but usually that doesn't project the image. It is a 2D image, so you don't get the depth perception. In AR headsets, you get the depth perception also. Project the image wherever you want it. It will improve the ergonomics, improve the neck and back pain, and the efficiency will increase. AR image can be magnified and adjusted by simple voice or gestures. Technology already available since past 5 years in all the cars. And in some cars, they will follow your eyes. So wherever you are watching, this image will be projected. It appears far-fetched, but it is not. Another benefit which will reduce the OT hardware. We don't want a Lenovo 400 or 800 occupying 20% of the OT space. This is the only thing we want, and this is the headset we want, and we can see like this. And this is going to come sooner than you think. And then we can superimpose radiology and anatomy. A resident doesn't know the anatomy, what to do. Simply superimpose the image. While you are operating, you'll get what are the nerves here as per anatomy, what are the vascular structures, and this is a mixture of superimposition and 3D navigation, already used in spine surgery. And we can get real-time warnings, like we are driving, take right turn, take left turn, and it can also give instructions during the procedure. And of course, we have talked about AI-enhanced surgical robot, that all these will improve operative efficiency. What about post-operative period? The AI algorithm will sift through the electronic health record, anticipate complications, and help us in reducing surgical site infections and enhance recovery. Our aim is earlier patient discharge and least morbidity for the patient, and AI will help us in that. Then there are technology disruptors. AI is one, other is the blockchain technology. Blockchain technology is with us for 10 years or more, but it got popular during COVID times when people start looking at cryptocurrency as a viable alternative. So what happens when I do a transaction through bank? I do a transaction, A gives to B. Bank keeps a record. But cryptocurrency, there is no need of keeping this record because we have a transparent block which is created for every transaction, and it is shared with all the users. So as the time proceeds, these blocks we keep on adding these blocks. The benefit, it is reliable, transparent. This is the relation between person A and B. Bank should not be there. So, and there is no chances of human error or manipulation by the heads of the state. So this may or may not come in currency because of various other reasons, but it can definitely come in health data management. So we can have patient-centered data management. So a patient has got a procedure done. So a block will be made and it will be available to everybody on demand. So a patient comes from X hospital, there is no need to send him back, get the biopsy report, get the slide for review. Everything is available at the click of the button. Faster diagnosis, and it will also provide additional safeguard against human error and greater trust in the hospitals and provider. In technology, and what could be the use of this technology in plastic surgery? We can have IoT sensors which can be implanted into dressings and implants. An implant is leaking, the surgeon, the patient, and the healthcare system will get a message. Dressing is soaked, message will be there. By the time surgeon or the dresser reaches home, Amazon or other such entity will deliver the dressing to the house. Everything is available because there will be remote patient monitoring. And in case we look at the overall cost, it appears that it will be very expensive. It will not be, because patient doesn't have to travel, and the diagnostic travel has to be reduced. And telehealth, that is what I think National Health Mission is also focusing more on telehealth. And it will also help in clinical trial management. And overall the cost will be lowered. Then we are talking about disruptors. What about biotechnology disruptors? We have seen 3D printing. What if the ink is replaced by cells? Same thing. The DICOM images, STL data set, and start printing. But the raw material is replaced by cells. So that will require autologous tissue culture and mix it with biomaterials and we'll get a bio ink. So biomaterials are gel, collagen and chitosan. These are commonly used. In printing technology, initially it was droplet based like an inkjet printer, but now more and more people are using extrusion technology because it is scalable, it is easy to operate and it is highly versatile. So plastic surgery could be at front of leading this technology because most of our requirement is a single cell based requirement, like we need cartilages. case of microtia comes, take a biopsy, expand the chondrocytes and mix it with ink, do DLP printing, put it in bioreactor, and all of us would have seen the image of this pinna on the back of it came out around 7-8 years back in PRS. And this is true. This is the ear which accomplished plastic surgeon makes through rib. This is the Medpor implant which you get. This is the image made by the biotechnology. So we can also make no need of rib graft or carving the cartilage for nasal reconstruction. Simply do 3D bioprinting. And moving forward, these are single cell cultures. For but skin, we need keratinocytes and fibroblasts. So again, we can use this and use gel and collagen scaffold and make a bioink. And we can print it directly on the burn wound. The laser will see what is the depth of the wound. First layer of fibroblast, which were expanded earlier, then the layer of keratinocyte directly on the wound. And this technology can be enhanced with a biomask. You can print the dressing simultaneously. It looks far-fetched, but it is not. I visited this Wake Forest Institute of Regenerative Medicine around 7 years back, and they were already printing. They are doing many other things, but these are the pictures they allowed me to take. This is the bioprinter using extrusion technology. So as a side hustle of this technology, what we can do, body on chip technology, or called BOC, in which the physiological responses can be tested. We can print different organs at the cells of those organs. We can use various drugs to see whether they are efficacious, whether there is drug toxicity. It will avoid animal testing altogether and lead to faster and safer drug discovery. And this is being commonly done in past 3 to 4 years. So, ladies and gentlemen, there is an exciting future in healthcare. But we have to adapt for the future of healthcare because there are changes ahead. And if you look at plastic surgery, the change has been the only constant. It has been only 45 years. The seniors sitting among us, they were doing tube flaps. Then they started doing perforator flaps, then microsurgery, then super microsurgery. They had a lot of objection to doing fillers and double matrices initially. But now all of them are doing it. So we are the ones who are always ready for change. This has been nature of our specialty. We have adapted. You see, initially when the microsurgery came, when we were residents, we can do it only in tertiary center where the support facilities are there. Now, even in villages, microsurgery is being done. Fat grafting, how can fat be panacea for everything? Now look at those accomplished microsurgeons, accomplished back surgeons, surgeons who describe diaphlaps are using fat grafting and not diaphlaps. Same thing with VAC, same thing with dermal templates most recently. So what happens is, initially there are some innovators, then there are early adopters, then majority, then this is Rogers diffusion curve of innovation. So that is exactly who we are. We always question, plastic will question status quo, they have divergent thinking, and they believe in innovation. Dr. Mohit just showed us an innovation. So I think most of us will follow this curve which I showed and will adapt to this. So during the childhood we have been told necessity is the mother of infection. No sir, no ma'am. Innovation is its identical twin. Innovation is the mother of invention. And we plastic surgeons are innovators. We have a unique personality. We have flair for creativity. And we are pragmatic. Usually you look at all the plastic surgeons, they are fairly pragmatic, not arrogant beings. And we are flexible. Our eyes light up whenever somebody talks of something new. There is a spirit of enthusiasm. And people say perfectionism is not good. But more often than not, plastic surgeons are perfectionists. And they have undaunted perseverance. You can do a fibula, finish it at 5 o'clock, and again come back at 2 a.m. to do a re-anasmosis or re-exploration. And then, even while doing that, be meticulous. All of us are like that. We collaborate across the specialties. We are expanding our horizons. Look at these. We might be hustler, inventor, explorer. I think most of us can fit here easily. So we are entrepreneurs and innovators. And innovators are leaders and they are destined to lead. So We are poised for groundbreaking future in healthcare. I hope when future arrives, we can say, dear future, I am ready. Or dear future, we all are ready. I would like to take a moment to thank my teachers, Professor Chari, Professor Ramesh Sharma, Professor Gautam Biswas, who not only initiated me into the journey of plastic surgery, but served as role models in various other aspects of life, both personal and professional. I would also like to thank the great doyens of plastic surgery, many of whom are in the audience, Dr. Kalra, Dr. Ravi Mahajan, Dr. Uppar, Dr. Vijay Obed. With your the strength, you motivate all of us. Thank you, sirs. I would like to thank my contemporaries and younger colleagues. Look at these faces, all of them bright and cheerful. There is no other option while with them except to grow. Thank you. And towards the end, I will thank Postgraduate Institute of Medical Education and Research, Chandigarh, India. It has been 28 years since I am here, and every single day I get opportunity to learn more. So that is the beauty of this place, and in accordance with its motto, service to humanity, care for the needy, research for good of all. Aaj Seva Sarv Bhadra Shodhasht. Thank you.
Respected sir, I'll greatly congratulate you on behalf of Executive Committee, the organizing committee, all the delegates and members for presenting such a wonderful oration. You've taken us on a flight which started from Sushruth, then C. Balakrishnan, and present times and the future. Maybe Star Trek when we were younger. Star Trek things used to be affection, but they are now true, the cell phones and all, the flip phones. So what you're saying will definitely come true. It was a wonderful presentation. So everybody must have felt that zeal and enthusiasm of what we'll all encounter in the coming future.
Yeah.
Thank you, sir, and congratulations.
Thank you.
So now it is the high time to honor Dr. Atul. So I request our chief guest, Dr. M.K. Garg, Madam Dr. Uma Garg, Dr. Nivesh Agarwal, Dr. Prashant Tyagi to kindly come on the stage.
Yes, sir. Thank you. Yes, please. Thank you.